Hello and welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a joint venture between the Digital Pathology Association and Path Presenter. A very useful product available for complementary to DPA members and a very useful learning tool. The patient today is a 49-year-old woman. And she's been experiencing several months of pain and edema in her leg and is found to have a pelvic sidewall mass. Now, of note in her history is that she is quite a number of years post-hysterectomy. And so most of the thinking about GYN sources for this tumor or mass would seem to be excluded. Here we can see the MRI and representative CT scan showing this mass here right up abutting with the ilium, somewhat complicated and locked in here with a number of issues. And interestingly, she had a PET scan to follow up, and this is the only area in her entire scan which has increased FDG uptake. So it's PET avid. It's clearly creating some symptoms, including pain and swelling, impairing her circulation. And so a biopsy is in order. With some difficulty, this sample was obtained, and we can see it's somewhat fragmented, variable amounts of sort of necrosis, probably some lymphoid tissue in the background here. And as we come in on higher magnification, we can begin to appreciate that there is a malignant neoplasm here. It's forming glands. It has some sore solid areas. Additionally, it's not really a high-grade tumor, but it does appear to be forming glands and have maybe a squamoid or solid characteristic. So this, I think, raises the question as to where the primary could have originated from. Now, of course, we have only the radiographic evidence of there not being another primary site. So one would ask yourself, could this be a primary tumor? Is this something that we would, consider as a primary? Well, obviously, there are not any epithelial structures that live in that location in the normal anatomical development process. But over time and a lifetime, various, how should we say, implants or ectopic tissues can develop. As we look at these cells a little bit more closely, we see there's a little bit of grumous debris here, but not much in the way of necrosis to suggest a colonic type of tumor. The cells are columnar, arborizing, sort of branching, tufting pattern of cells. And so this, I think, brings up a number of interesting differential considerations. And that oftentimes will lead to a panel of immunohistochemical stains. So what do we think about in this situation? Well, I think one question would be, what would define a metastasis as a so-called gynecologic tumor of origin? And certainly the important things to think of first are, what is the morphology? While we know that many different things can mimic both the primary ovarian tumors as well as vice versa, we do want to rely on morphology because that is one of the areas where we have so much experience and a good chance to make a best estimate. The history can oftentimes be useful, although in this situation of 17 years previously, there aren't very many tumors that recur of that sort, and we don't have any evidence that her hysterectomy was done for malignant disease. Can gynecologic primaries arise in the absence of existing gynecologic organs? Well, yes, certainly. Patients can have endometriosis that can develop gynecologic type tumors. We see mucinocystic neoplasms with ovarian type stroma in the pancreas and other sites. But lacking either of this historical issue, sometimes the immunohistochemical profile will be helpful for us. Specifically endometrioid tumors, I think if we have good hormone expression, if we have characteristic P16 pattern of the patchy cellular expression, if we have PAX8 positivity, maybe Vimentin positivity, though that's not quite as specific, and a negative P53 stain, that's pretty good evidence for an endometrioid phenotype. Serous high-grade tumors, either endometrial or ovarian, having strong P53 mutation patterns, strong P16 expression, and potentially also WT1 expression, that can also steer one towards a serous high-grade lesion. The difficulties and the pitfalls with regard to defining a tumor as gynecologic in origin primarily are in the areas where we have mucinous tumors that have enteric phenotypes. Those promiscuous type of immunophenotypes, very difficult to define reliably as one side or the other on the basis of the immunophenotype, unless there are certain types which say express PAX8 and so forth. Of course, we also know that there are other P53 mutated tumors, and we need to be aware of those, as well as other tumors which can express PAX8. Thyroid tumors, some bladder cancers, including adenocarcinomas, and of course, renal carcinomas, thymic tumors may also express PAX8. So in our particular patient, what were the findings? Well, the patient did express PAX8. The tumor did express a patchy P16 positivity. It did express ER and PR and was P53 negative. So we felt we should sign this out as an adenocarcinoma, most consistent with an endometrioid type adenocarcinoma. We'd have to postulate that this is a primary tumor potentially arising from long-standing endometriosis. But in either event, that phenotype is helpful in getting the patient into an appropriate treatment arm, hopefully with drugs that will be effective for her in helping her symptoms. So I thought that was an interesting question to approach, not an uncommon situation, and certainly illustrates what I consider to be sufficient to classify a lesion as being of gynecologic origin. So I hope you enjoyed that, and if you did, please subscribe. It always helps if we have easy access to get you those new releases as they come out on our channel. And if you have friends or colleagues who are dealing with some of these challenges in their work, please don't hesitate to share this video with them and send it their way. Thank you so much for joining me today. And so until next time, it's been our pleasure, and we hope that we will see you again soon.